Hello, everyone. I'm Mark Plaster, and this is EP Talk, the place where emergency physicians, aka ER docs, come to talk about things that are important to us. Sometimes professional, sometimes personal, and certainly we try to stay on the cutting edge of developments. And my guest today is Rich Fabian. He's the CEO and president of you can see behind him Fujifilm Sonosite, and we're going to be talking about peripheral IVs using Sonosite. Well, Rich, thanks for coming on the podcast.
It's my pleasure. Thanks, Mark, for having me and talking about this important topic.
Yeah. I understand that you've been in the healthcare field for at least 20 years after getting a BA from Michigan, an MBA from Pittsburgh, and then 15 years with Philips, and now 5 years with Fujifilm Sonosite. So you've been around a while to know a lot about healthcare innovation. So I'm interested to talk to you about one of the most overlooked skills and requirements that are anywhere in the emergency department, and that's IV access. Because you and I both know that when it goes well, it's easy. It looks like anybody could do it, and there are. So you have the IV whisperers, the nurses in the ER or the peds ICU who can always find a vein and get to access. And then there are times at which you're actually doing Hail Marys and sweating bullets and praying that you can find that vessel in an emergency or just on a little kid or in situations. And so we're here to talk about using the ultrasound as a way of doing that. And I know that our younger set of physicians who are coming out are very familiar with using ultrasound, but we're really wanting to see that expand. And I think Sonosite is trying to bring that into actually universal acceptance and skill. So I'll throw that in there just simply to say, tell me a little bit about ultrasound guided peripheral access IVs.
Absolutely. And you mentioned it earlier. When it goes well, people don't talk about it. But it actually is one of the most emotional things that can happen at the hospital when it doesn't go well, or when it doesn't go well to yourself, your family, your child, because it's painful and it's memorable and it's actually what's interesting, and I'm sure you've seen it over the years. When it doesn't go well, that's what the patient remembers, or the patient's family, long after whatever they were in the hospital for originally.
They poked me 50 times. I couldn't believe it. They called in 5 people and they never could seem to get it. And it seems like once you miss the first time, then everything starts to go south. Everybody gets nervous. You miss more and more times. You develop hematomas. You start going after different vessels. And then then you're calling people from the floor.
And the other thing about peripheral IV that maybe you don't think about, but it's pretty intuitive, is it's actually the #1 procedure that happens at a hospital.
Right.
Almost every person, 99% plus of people who are admitted to a hospital, have an IV.
Yeah.
And so it's a very, very common procedure.
Yeah.
And it's also something that we've seen over the years, that with ultrasound guidance, the chance of getting it right the first time is extremely high. As a matter of fact, it approaches 100%. We've seen kind of the before and after of, where hospitals are operating somewhere between 60 and 80% of first time right sticks after using and standardizing on ultrasound guided insertions. It's very close. Depending on how long and how well trained the team is, it's approaching 100% at facilities, which is such a relief, not only for the patients, but you mentioned it earlier, it's not easy on staff. And as we take a look at physicians, nurses under more and more pressure and stress, the investment of the hospital into a program that is improved patient care and an investment in them with not only ultrasound equipment but training, that means a great deal to the caregiver as well.
Yeah, yeah. Sometimes it's like I say, when it goes well, nobody even thinks about it. Okay, but how many times in my practice have I seen care delayed by sometimes hours because they're looking for somebody who they've already tried 4 or 5 times. Now the patient's angry, they're frightened. The parent is in there. Find me somebody who can do this. I'm not letting that person touch my child again, or and then that just builds on the anxiety of the patient and the team. And the next thing you know, everybody in the ER or on the floor or whatever, they're all standing around. It's like a cheering squad. They're all standing around trying to hope and pray that they get a line in that doesn't blow and that is usable. And then there's another aspect of it. There's oftentimes care that you look at the patient and you say, I'm not sure I want to try an intravenous therapy on this patient because I'm not sure we can get in. You talked about the percent of time has gone up to near 100%. What does that translate to in time? Do you have any feeling, or are there any kind of time studies that have said it goes from this amount of time to this amount of time? Is that an impossible question? I apologize if it is.
Those are great questions. And actually, we'd love to do more pre and post implementation of the program studies on that. But we do know there's certain elements, there's costs, there are soft costs, and then there are real costs that happen by delayed peripheral IV. Of course, most important cost is, especially in an emergency situation, patient care, because the sooner you can get the IV placed, the sooner you can take care of the patient.
Yeah.
After that, you're right. I mean, of course, the more sticks, danger of infection is increased. Yeah. There are real costs to timing. Let's just say a difficult stick could be 10 to 15 minutes.
Yeah.
I don't think that's an unusual
no
or an outrageous estimate. So if you're saving 15 minutes on 20% of your patients, you can do the calculation on how much time you're freeing up for the nursing team and for the entire department to take care of patients instead of sit around strategizing about a needle placement.
Yeah, then I would actually probably place that number a lot higher, because I've just seen a lot of difficult. Depends on where you work, of course. But if you work in the city, you've got a lot of IV drug abusers. You've got they walk in the door and everybody starts sweating bullets, thinking, where am I going to find a vessel? And then they start telling right away, we need central lines, we need IOs, we need all kinds of alternative things that you would probably not want to do, simply because everybody, the nurses look at you and say, no way, I will not be able to get into this patient. So it's not going to happen.
You also are dealing with different populations. Obesity makes it more and more difficult. We've seen dialysis patients that become very, very difficult to find. And then there's just certain percent of the population where it's tough, as well as the most difficult. And it's difficult as for any parent to watch. Pediatrics are another area where needle sticks and IV placement can be quite difficult.
Yeah, that's exactly right. So the question here is, a lot of the folks in emergency medicine who are just now coming out of training, in fact, I would say the majority of them have some training in ultrasound, but they're seldom the ones who are actually placing the IVs, unless unless the patient has failed at multiple attempts by the nursing staff or the IV team or whoever it is that starts your IVs. So if I understand correctly, you're talking about actually training more than just doctors to put in ultrasound guided IVs, but actually the staff. Tell me about that.
Yeah, so I think a lot of times people think the answer's the technology. And of course, at Sonosite, we love our technology and we think it's fantastic. And we take pride even in creating this space of point of care ultrasound back over 20 years ago.
Yeah.
But the reality is that to have a program like this, it goes way beyond just the equipment. It goes into the training. We have a program where we do train the trainer. I think for this to be successful at the facility where we're implementing, you need a commitment to ultrasound guided peripheral IV from the leadership. We've seen that
Right.
is probably the biggest factor in driving the success. And we have both internal resources. We have a great team of clinical specialists who can help do the training for train the trainer. But we've also partnered with nurses throughout the country who are specifically trained on use of ultrasound guided peripheral IV that will go out and train the trainer at the different facilities. And as what we've seen is, as soon as it's adopted by a group and they start doing the training deeper and deeper into the organization, it becomes embraced throughout the organization, almost to the point where the facilities won't do a line placement without ultrasound guidance. They just have become that comfortable with it. And, you know, you've mentioned it with physicians, and of course we see coming out of school, a lot of the, almost every physician in medical school, definitely in residency, where they're exposed to ultrasound in all areas of healthcare. It doesn't matter, emergency, anesthesia, even areas like surgery and ortho. We're seeing more and more ultrasound in residencies. Same thing goes with nursing, where if you are coming out of nursing school, you've probably been exposed to the use and a little more comfortable with ultrasound than somebody who's been in nursing for the past 15, right. 20, 25 years. Right. So the idea here is with the training and with the, clinical team, Sonosite clinical team, as well as our partners that we use for the training, that we want to make sure that the entire community is comfortable with the use of ultrasound. I would tell you, some of the people that you would never expect who've been nursing for the past 25, 30 years, never even have used ultrasound, are some of the strongest users once they get comfortable and understand how to leverage the technology and what it does to patient care. I mean, nurses are absolutely incredible in how much they value taking care of the patient satisfaction. Sure. And those are when you just see somebody smile and that what you suspect is going to be a difficult stick go well, that's unforgettable. And that is really an incredible transformation we've been able to see, and we're very proud that we've been a part of that journey. I still think there's huge opportunity for more and more adoption, though.
Give me an example of a specific, kind of walk me through the process of, maybe you can give us the name of a hospital or a site where you guys have done one of these programs. Maybe you just kind of leave it unnamed, but kind of walk through the process. Somebody takes this, becomes a champion for this process and does X, and then what happens?
Sure, I'll tell you. We have a couple examples, that I can speak to, and one is a community hospital in New Jersey. Mm-hmm. That's published quite a bit about this. Another is a large academic institution in Chicago. Again, very they've published and there's some strong data. I think that the best thing to do as you're thinking about this program, get a benchmark. Start understanding what performance is of peripheral IV upfront without using technology. Bring in make the investment in technology and do a post follow-up. What you'll see is there are incredible rates of adoption of this program. So and you'll start to see patient satisfaction scores increase. As a matter of fact, I was just at ASEP in San Fran, but we heard from physicians we were talking to that one of the biggest dissatisfiers in patient surveys is that initial
Right.
IV placement.
Well,
If
of
it
course.
does not go well, so you start to see patient satisfaction scores increase, the timing and the patient experience improve. Something that can, if you think of how many options there are or there are not to improve healthcare, maybe even for a hospital. I know we're getting now on the business side of things, but at a hospital, this is also something that could swing market share to your facility. If you're in a town with two hospitals, one is marketing that they have a peripheral IV program, one stick standard, and the other is not. I can tell you where most people will
Yeah.
end
Yeah.
up going if they know that the technology is out there. So for a relatively low investment, high impact, and this is an impact that can that can affect patient satisfaction, staff satisfaction. Most like we know it's a saving in time and energy,
Yeah.
and I think that this is what I would call a low risk, high impact implementation that doesn't really exist that often these days in healthcare.
So I couldn't agree more. I think about the frustration and that a nurse feels when they're defeated in getting an IV in, and they go to the doctor. The doctor is busy. They don't want to break what they're doing to go back and do your job. Go do your job. Go get that IV. They try half a dozen times, and eventually they say I can't do it. I mean
Yep.
that is a defeat. We're not even looking at it from the perspective of the patient. We're looking at it from the perspective of the nurse, and that's a bad day. That creates a bad day, a bad taste. Everybody goes home dissatisfied, the nurse included, the doctor, because he had to break what he was doing to go get that IV in, and now you're giving them an opportunity to say to the patient, your very first experience, generally, which is with actually medical care, which is going to be an IV, is going to be at the top of our game technologically, and it's likely to be successful. You're absolutely right. Everybody's going to go home, um, uh, satisfied with that kind of thing. Can you give me an idea of an example of of how fast you think about ultrasound? I think old dogs like me, although I've done this, but still, you're working in a community hospital. You're a mature physician. You're not used to using ultrasound to do this. And you think, oh, I got to get out the ultrasound. I got to get this. I got to get that. Da, 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 da. How long does it really take to set up an ultrasound guided peripheral IV placement?
So I think one of my favorite sayings in life is everything's difficult before it's easy. And I've seen that in my personal life as I try to learn any new skills or in my professional life as well. And I think that applies to a program like this. What I would, there are certain things that you can do to tip the scales in your favor for a successful implementation. Number one is to make sure that you have dedicated ultrasounds for the IV team. What I've seen is where you have departmental, if it's in the emergency department, dedicated for that, and you're trying to borrow it for difficult sticks, it becomes very difficult. So I'd say number one, make the investment in the technology and have it accessible. Number two is partner with someone like, we're dedicated. We live in this space. This is what we do,
Right.
and we've recognized that this is going to be way more than us sending a video or a YouTube clip and saying in equipment and saying good luck. I think there needs to be commitment from leadership of the hospital and especially the nursing community
Sure.
to implement and to train, take the time to train and invest in the team. Having said that, once you see it, it's like anything. It's a skill that you develop, but I will also say the use of ultrasound is in identifying the vein and inserting the needle correctly. After you've done it a few times, especially on phantoms or however you've practiced,
Mhm.
becomes quite easy. So I would say that, I don't want to minimize the effort, but this is something that can be implemented and rolled out through the facility in a matter of weeks and months, not years. And so, again, I've talked about it. I do think that this is one of those. I won't say low effort because there's nothing these days that's low effort, but
Right.
uh, with the right level of focus, commitment, and resources, this can be done. This can be one of the greatest impacts in the department in a very quick and efficient manner.
Yeah, I'm looking at my viewers, ER docs like myself, who've worked most of their careers and maybe currently in community settings, where we're actually this would be like you say, a real impact move, and it's not being currently done. Um, and one person in the department says, "Let's do this." How would they implement that? Who would be what's the normal process for Dr. Smith to say, I want to implement a ultrasound guided peripheral IV access placement program? Go to the department chair, go to the president, vice. I mean, is there a talk to? I mean, you're the CEO. They're not going to call you. I mean, how do they implement that kind of decision?
So I think that, I mentioned it earlier, it has to come from the top and supported from the top. I would say that depending on, the emergency department and who places the IV. I've talked to many where it's the nursing staff. I was talking to somebody last month where they were saying it's the EMTs who place them. And so I think understanding, which group would benefit the most, I would say primarily it would come from the nursing team. What I
Okay.
love about the chief nursing officer championing this effort is I think they have the hardest job in the hospital, the CNOs. And when you're looking around the executive team, I can just imagine, I've not been in that meeting, but I can imagine that as they're looking around the table, the chief nursing officer is probably getting beat up month after month
Right.
for, costs are too high, turnovers too high. We need better efficiency. And and with a program like this, I can imagine we're finally given a tool and a program to help resolve some of these issues that
Yeah.
that that we're not only the nursing team but the entire hospital's suffering from. So
Yeah.
it could come from the CEO, absolutely. It could come, but I think this would also be a tremendous win for the chief nursing officer who's, can implement something
Right.
that is, huge impact and huge impact. It's measurable. They can, you also talk about what can, depending on, academic or what community facility, but like here you are, you have something pre and post to
Yeah.
show how the program you've implemented is doing. You can measure satisfaction of patients, of nurses, of emergency physicians. This is a program that will impact across the organization. One more comment is we used to talk about the triple aim. Remember that a few years ago? It became the quadruple aim because caregivers said, hey, you're forgetting about us in this equation of triple aim. Triple aim used to be how do you improve access to care, treat more patients? Absolutely. This improves access to care. How do you get a better result, or how do you treat patients better? I think this is a proof point of that.
Yeah.
How do you do that while being reducing expenses? you will see, and we talked about it earlier, this program will pay for itself probably quickly. And how do you do that? All while taking care of the caregiver, the physician, the nurse, whoever is doing this. This not only fits in the quadruple aim, I think it's a poster child for what triple aim should look like, quadruple aim should look like in these days.
Yeah, yeah, yeah. What do you get? You're in a position to say where the emergency departments and hospitals of the country are currently. How many of them have ultrasound guided peripheral IV access placement? What would be the percent of hospitals that have that, and what do you see as the potential? Obviously 100%, but I mean, what do you give me an idea of where you stand?
So we see it's a fraction of all facilities are using something like this. And of course, on occasion, some places will pull out the ultrasound for a very difficult stick. I wouldn't call that a program. I'd call it a program where you have the equipment, you have the training, you have the measurements, and so from that perspective, we are in the probably high single digits.
Wow.
Some are, close to 10, but under 10% of facilities have a program like this.
Right.
I think that this is something that once more facilities understand the benefits, we're going to see this really snowball and become much more popular. I'd love to see this approaching 100% because I think, we have the technology, we have the need. This is, to me, just such a great opportunity. And I appreciate you highlighting this on this today, because I think that as more and more people become aware of the technology and the program, we're going to see more and more demand for this across the entire medical field.
Yeah, we're about to wrap this up, but let me summarize this a little bit for our viewers. The usually the very first technical interaction that doctors and that nurse, even EMTs, have with the patient is the placement of an IV. It's anxiety producing on the part of the patient. It can be anxiety on the producer on the part of the operator. And if it goes poorly, if it goes well, it's nothing. Okay. But if it goes poorly, and it goes poorly more than we like to think about it, because we're not there. The physicians are not there seeing this. We see the Band-Aids when they come rolling in with the 2, 3, 4 sticks. But we don't necessarily see what kind of trauma has already occurred in the patient's mind and in the operator's mind, for that matter. Okay. And the cost and the additional problems and such. And so it is out of sight, out of mind. And I think that Rich's point here is something that we as physicians need to be more cognizant of, and that is that patients and our staff, be it EMTs, IV team, or nurses, are dealing with a problem that really impacts how the patient sees me as the caregiver and the hospital as an institution. If their very first interaction is flood, and they struggle to even get an IV in. Where do we go from recovering, from that? So I would encourage people to just start to think about this. Think about that very first experience that a patient has, whether it's a child or an adult, has with your hospital. If that demonstrates technological excellence, cutting edge technology, success, it translates into pain. That translates into what the patient thinks of you and the hospital, and it translates into time. And I hate to say it, it translates into money. Okay. It translates into money. And so to my viewers, if you're not involved in a program like this and you think, the only people doing ultrasound should be me. Well, that's wrong. Nurses can do it, EMTs can do it, it can be trained to do it, and it turns out to be something that can free you up. And I really think that, Rich, thanks for coming on and talking about this, because this was anybody who's taken a kid to the ER, anybody who's had 2, 3, 4, 5 sticks in the ER trying to get an IV in place, knows just how traumatizing that could be to everybody. And so think about it. I hope that emergency physicians, even though it might not directly affect you, because sure, I could go in with an ultrasound, I can find it, I can put it in, I look like a hero. But now they've already been traumatized. They've already made their decisions. Their impressions of what your staff and the hospital do. So think about this. And it's not just, we're not Rich is not just selling technology. He's really looking at how to take that technology and implement it through training and exercising technological excellence. So everyone, thanks for joining us today. Rich, thank you for joining the podcast.
My pleasure. Thank you.
I hope this has created some food for thought from the physicians and others who watch our discussion here at EP Talk. And Rich, thank you for joining us.
Thank you.